thank you for being here today on the talk on osteoporosis. This is a talk I have more experience giving to medical students than other physicians. I work a lot of times for a pharmaceutical company giving talks on osteoporosis for a particular pharmaceutical line that they promote here around the United States. So it is kind of nice to be able to talk today about osteoporosis one-on-one with patients and local citizens of Fairfield. And I think this has been a great situation with the hospital today. Nice turnout, and it's always nice to see people here concerned about preventative medicine. So oftentimes when I see people, it's not for prevention, but for response to acute illnesses. So it's fun to be able to talk here today on a topic which we see quite a bit of in the office. And I judge by the age average of the crowd here, you have a natural concern for also. So today's topic goals will be to pretty much define what osteoporosis is, look at some of the realities involved with osteoporosis as far as what it means to you medically, what some of the costs of osteoporosis are to the United States for health care, and more particularly later on defining some things you can do for preventative medicine to help prevent the progression of osteoporosis, and then also talk about some of the treatment modalities out there that you're going to be hearing a lot more about in the next few years, since osteoporosis is really becoming a great focus in medicine with physicians in our journals and lectures. That's been really pretty lenient, or not lenient, for the past 10 or 15 years, and is really becoming a focus, and I'll explain why here in a few minutes. So I'm going to start with my first slide here, if I can get this thing working right. First off, when I do speaking, I always remind people that there are repercussions for disagreeing with me. You're welcome to disagree with me, but I have talked to God already, and those who disagree with me are going to be burning in hell. So if you have any questions today, I'll take it in good humor. But I do promise to present to you today that all the information I give you is medically accepted by research. And we're talking large-scale studies, of which I'm speaking about, on the basic facts. The first slide, and I've only got about 8 or 9 slides to show you, so we won't be looking at this the entire of the lecture, is the realization that the United States population is growing older. And this is a simple graph that shows that roughly in the next 50 years, we're going to be seeing a doubling of individuals over 65. So that by the year 2050 to 2040, they're estimating our population to be almost 80 million people above the age of 65 in the United States alone. If we look more specifically at the female population, which are primarily concerned with osteoporosis, although we'll talk a little bit about male osteoporosis later on, we've gone from 1990, a population in the United States of people over 65, from 18 million people to the year 2020 projected to be 25 million women over the age of 65 in the United States. So you're going to be living longer, hopefully you're going to be living healthier, and so that is something of significance when you consider that many of the other disease processes come on as you get older. We do know from statistical analysis that for the 150 years we've been able to take good census of aging data, that the aging population, for female particularly, is increasing. It's no doubt, no secret to any of you that you're living longer than you did with your grandma, your grandpa, your great-great-grandma. And if we look back to the average longevity in the mid-1800s, it was not unusual to be average life expectancy to be 50 years of age. But at the present time, the average longevity for a female is above 80. Now what's important about this is that the actual age, average of menopause has remained relatively constant. Average age of menopause is around 50 in the United States. So despite the fact that we're living longer, we're not delaying osteoporosis, or excuse me, menopause longer. Now what's significant about that is that roughly 1/3 of you will be living your life post-menopausally. And what's significant about that is that after menopause, you have a lot of other disorders that start creeping up in response to the lack of certain hormones that you're not producing anymore. And particularly on the topic today of osteoporosis. Now, I throw this slide up and I give this to my medical students when I talk, and also to physicians, about the perception of what you think you're going to die of, since we're talking about getting older. And they did a Gallup survey of an average age of women around 50, 55 years of age. And they asked the ladies, what do you think you're going to die of? What do you think is the leading cause of death as you get older? And quite interestingly, 40% of women believe they're going to die of breast cancer, nationally. What's also interesting that the second leading cause of death that they feel they're going to die from is heart disease, which encompasses stroke, heart attacks, hypertension, and the complications thereof. But the reality is not that. The reality in the United States is that actually 45% of the ladies in this room will die of heart-related diseases, stroke, hypertension, complications, and heart attack, which is contrary. Remember, they said 19% of what their perception was. But let's look at breast cancer. So we have a fair number of women here in the room today. How many women actually die from breast cancer in the United States? And despite all the risks that you hear, about 20%, 12% risk of getting breast cancer, only 4% of women in the United States die from breast cancer. Contrary to your perception, that 45% of you believe that you're going to die from breast cancer. In reality, only 4% do. Now, there are various reasons for that, but that's not for the topic today. That's another lecture for that. But what's significant about that fact for you is that many of the new agents that are coming out medically by prescription route are geared toward that perception reality. In other words, new medicines that are evolving now that are being given by the doctor's offices are focusing in on measures to help prevent heart disease besides osteoporosis, and also focused in on the idea of helping to prevent breast cancer. And you're going to see in the next 10 to 15 years a little explosion of new medications out there for the therapy of osteoporosis that will also benefit heart disease and the reduction of breast cancer. So they've aimed their therapy based on your perception and the reality of what's really out there for causing death in the United States. Now let's get to the scope for our practice. Let me get caught up my notes here just for a second. The scope of osteoporosis is that roughly 28 million Americans have low bone mass, meaning osteoporosis. Now, what that means to society, if I could jump ahead here a little bit, at the bottom is that it accounts to, in the United States, about $14 billion a year of medical costs to the citizens of the United States for insurance companies and private pay. $14 billion is a lot of money. It's nowhere near the cost for heart disease, which is over $200 billion. But it's still significant. And so the insurance companies, the pharmaceutical industry realizes that, and so they have a reason to want to promote the perception of taking care of yourself for osteoporosis, which is good health care. But there is a financial bottom dollar here, which unfortunately, as you realize with medicine, still comes down to that you have to take into consideration. But what's interesting about statistics, these slides are really outdated in the sense that one of the risk factors is, well, who's going to get osteoporosis as a female? And I will tell you that in this room, about 84% of you will have some degree of osteoporosis. I don't care what you do, at this point in your life, about 84% will have some degree of osteoporosis. Because we know statistically that by the time a woman is 70, only 16% of women will have normal bone mass or osteoporosis. 16%. Another 54% will have thin bones, not classified as really brittle, fragile bones, but they're thinning and place you at risk for broken bones later on. And another 30% of those individuals will have classified osteoporosis, which is a medical jargon for us based on certain tests we do on how thin your bones are. But the reality comes down to the fact that over 3/4 of you, over 80% of you, will have some degree of bone thinning as you age past menopause. That bears significance to give consideration to. Now, let's review what the bones are, your skeleton, since we're talking about osteoporosis. What does the skeleton do? We know that the skeleton is holding this huge mass of me up here today. I'm just not a mass of ligaments and strong muscles holding me up here. My bone structure is giving me support. So we know your skeleton is the way to give you support. That's a gimme. But the bones also serve another function, two other primary functions. They help make blood so that you don't become anemic and restore new blood cells. But also they're an important vehicle for serving as a depot of storage of very basic elements. Particularly if we're speaking in terms of calcium, magnesium, and phosphorus. When you go to the doctor and you measure your calcium in your blood, you're only looking at 1% of your total body calcium that's in the circulation. The remaining 99% is actually in your bone being stored with an active rate of turnover. And like all the other organs in your body, the bone is in constant change. It's always evolving on producing and restoring itself, which allows itself then to grow as we grow into from teenagers to adulthood. It allows you the chance to remodel and to heal your bone when you have broken bones, and then allows you a way to give those important chemicals I mentioned, calcium, phosphorus, magnesium, into your circulation. Because just for bones, they're also important for the nervous system, the cardiovascular system, for heart regularity, your psyche as far as confusion, dementia. They're also very important elements in that regard. Now, as far as this remodeling concept is concerned, just for your own education, it's by two primary types of cells. One is called osteoclasts, one's called osteoblasts. Osteoclasts are cells that get in your bone and they eat in your bone. They're working all the time taking calcium out of your bone because they know they got to provide calcium to your body, magnesium and phosphorus to your body for that important functions we talked about earlier with the neurological system, cardiovascular system. But offset by that then, your body has a beautiful gift of supplying itself with osteoblasts, which are cells that help you remodel your bone. They put calcium and magnesium back into the bone that your body's taken away from itself. So the body is a very miraculous constructive instrument here. It has so many ways that it counterbalances its effects of remodeling and healing itself. And as a matter of fact, in a year's time, roughly 1/3 of your bone will have been remodeled. Hard to believe the way you're sitting there, that roughly if you took 1/3 of your body away, 1/3 of that your body will have had itself remodeled internally of the bone structure in a year's time. So just figuring about 3 years, you've got basically all new bone structure. Now, the foundation for this bone remodeling with osteoclasts, osteoblasts, etc., is dependent upon some very important chemical properties to your body. With the female population here today, it has to do with your estrogen, but also some other hormones such as parathyroid hormone, etc. But estrogen for this audience today is a big culprit that you have to be aware of, as is testosterone in men. And we're now finding out that also estrogen is important in men, as of a research article just 2 months ago that I've spoken on. Now, what is osteoporosis? I've been throwing that term around. You all have an idea what osteoporosis is. Out of about everyone, if I went around the room, if I ask you what osteoporosis is, you'd all, because I've asked this even with other people I've talked to in the past, what is it? And you say it's part of an aging process of the bone. But we're going to redefine osteoporosis today. Osteoporosis is a disease of the bone. It's not a natural process of aging, it's a disease that up until the last 10 or 15 years we've really never truly appreciated to call it that way. It's a disease where the body loses its ability to remodel and to bring back calcium back into that bone again. And as a result, your bones become brittle. In place, you have tremendous higher risk for fracture and some other things we're going to talk about here in a second. And what's interesting is that when I'm looking at the audience here, maybe majority if not the case, by the time you're 30, your bones have already reached their maximum peak of bone density. By the age of 30, you're pretty well done getting your peak bone structure for as far as density and strength is concerned. And by the time you're 40, after that, you know the old joke, after you're 40, it's all downhill. It's true when it comes out. It's true with the bones. At that point of time on, you no longer keep up with your rate of replenishing and restoring your bone back to the youthful self. There's a slow decline. Which brings us then to our two basic types of osteoporosis. Type 1, which is the one that you're all aware of. Lack of estrogen, lack of some hormone balance that causes a rapid deterioration of your bone as you age. And just for statistical analysis purposes, so you know what percentage, in case you have an interest, for every year after menopause, when you go through your change, if you don't take therapy for osteoporosis, you lose roughly 3 to 5% of your bone mass. 3 to 5% in 5 years, that's 15 to 25% of your bone density. The strength of your bone to prevent fracture is gone after 5 years. After 5 years, it goes down to 1% per year. So there's really a dramatic decline in your ability to remodel your bone at menopause for the first 5 years. And that's why so oftentimes, if a physician and you talk about the issue, that he's after you to try to get you to take something to try to prevent that, because we know that's a big magic window. If you start your therapy later, there's still benefit, but that first 5 years is critical to begin therapy. The second type that I mentioned after the first type is the more common one, the aging, the downhill after 40 type situation, where just because of natural processes, your cells, the osteoclasts and osteoblasts, typically just don't keep the normal balance. And so the osteoclasts start winning the ball game over the osteoblasts. So that you start getting more natural bone deterioration and you don't have an ability to remodel the bone like you used to. Now, what causes some of the osteoporosis? Before we get into that, I want to talk about a statistic we know also. It's only about 1/4 of you will talk to your doctor about osteoporosis. Maybe after today's presentation, maybe after it's on FPAC a few times, somebody will start talking to their doctors about it. But only about 1/4 of the women talk to their physician about osteoporosis. And probably only about 1/4 of the doctors bring it up to their patients about osteoporosis. Because you have to remember where our mindset has been. Despite our aspect about preventive medicine, all through medical school you're structured on treatment of disease. And so the physicians over the past, particularly the past decade, had to, despite our lip service talking about preventive medicine, have really had to start changing our thinking, start thinking about more prevention in the office. And setting aside an office and start talking about osteoporosis, prevention of heart disease, prevention of colon cancer, instead of just giving you a pill for blood pressure and start talking about a scope every 3 to 5 years. So it's your fault and it's our fault both, our fault also that's not being discussed. What's interesting, that only right now about only half the women are taking any therapy for osteoporosis in the United States. And what's interesting, that most women who do take hormone replacement therapy, this is a physician slide, very few people are going to maintain their therapy because of compliance. We know that when you walk in the doctor's office, only about 1/3 of you will keep taking your medicine like you're supposed to. Now I know I'm looking here, I know all of you take your medicine like you're supposed to. I got a perfect crowd today. So the other 2/3 out there are not doing a very good job. And because the worry of side effects, for example, it's no doubt most of you are worried about taking hormones for breast cancer concerns, breast tenderness side effects, uterine bleeding, uterine cancer risk. And so even though they got built my bones, I don't hurt today, I don't have problems with my bones, it costs me money, I'd rather do without it than to take a medicine to make my breast sore, make me have a potential bleed or uterine cancer. So that's why only 1/3 of women stay on estrogen therapy after 2 years of therapy. Not very high odds, considering the benefits that if I have time I'll go into. Now, what are some risk factors for causing osteoporosis? And this is just some very simple ideas, and I'll mention a few other on the side. Things that you can change for yourself to help prevent osteoporosis. We know that smoking is a risk factor for osteoporosis, men and women both. We also know a sedentary lifestyle is a big contributing factor for osteoporosis. The body needs impact type exercise to prevent bone thinning. Now I used to think, before I got on this lecture circuit, that riding a bicycle, swimming, was good exercise for osteoporosis. It's great exercise for the heart. It's lousy exercise for the bone. You have to have passive resistance type exercise with impact. There's an electrical conduction system in your bone that stimulates these cells to work better if you have impact on the bone. And resistance training, where it's having to torque more on the bone and twist the bone. So I don't want you leaving today thinking you're all failures because you ride your bicycle and you swim every day, because I can tell we're all got a bunch of swimmers in here today. It's important that you get into a walking program. Try to, if you can, get into a program with some light weightlifting. Doesn't have to be over the head bench press, etc. Just some light wrist weights when you're walking to do some toning. Because we know besides the benefits of the bone, it also helps dramatically the heart and your muscle tone as you get older to do some light weight lifting. And I got to admit, I don't do a weightlifting myself except my fork to my mouth, as you can obviously see here today. But I'm going to change because I'm past 40. And it's all downhill right now. All right. Some things that are treating, and we're going to talk about treatment later on, certain elements of treatment. Comorbid factors. Some of you today may have rheumatoid arthritis. Some of you may be on special medications for high blood pressure. And there's about 40 or 50 drugs that I see we typically use that place you at risk for osteoporosis. For example, if you have high blood pressure and you take thiazide, hydrochlorothiazide, one of the cheapest, longest medicines you use years, it places you at risk for osteoporosis. If you have rheumatoid arthritis or you have lung disease and you have to be on prednisone, it places you at significant risk for osteoporosis. All you have to be on prednisone is 3 months at a dose over 7.5 milligrams a day for 3 months, and you're at tremendous risk for osteoporosis. Things that you can't modify, that you're stuck with. The age of menopause, we've just talked about. You're going to live 1/3 of your age after menopause, which means you're deficient of estrogen to prevent bone thinning. We know that certain races are more prone for osteoporosis. We know that Asian descent are more prone. We know that Caucasians are more prone. People who have less incidence are the black population. They have roughly 1/3 the risk that we do for osteoporosis. This is one that always kind of gets me. We're always telling you about losing weight. But if you become slender, you're at risk for osteoporosis. And the reason being is estrogen, female hormone, stored in body fat. If you lose your body fat, you don't have your estrogen stores, which help keep up the calcium metabolism in your body. So it's kind of like you're damned if you do and damned if you don't. You can live to be 100 with thinny, but you got maybe 3 or 4 fractures by the time you're 90 years old. Family history, I do see genetic predispositions in the office, and it's statistically proven that if you have an aunt or a mother or a grandma that's like this, that you said she's part of aging, she's got osteoporosis severe, and you're at high risk for getting it also. Without even doing a test, if you have a mother or a grandmother or a sister with this, you're at high risk for osteoporosis. Smoking alcohol. We don't have alcohol up there. If you drink alcohol, it puts you at risk. Now, we got to define how much though, because now we're telling you 3 glasses of wine a week is good for your heart. So we got a bunch of people not dying of heart attacks, but they're all in an alcoholic rehab organization in the United States here right now. So I'm very careful what I tell about to have a drink. And one of the classic things I always ask a nice little 80-year-old lady who says she doesn't drink, it says it's time to get started. So I think that if you keep it to 3 drinks a week, your osteoporosis risk factor is not significant. Although I always caution people, don't think about even trying if you have anybody in the family that's had been an alcoholic, because that's another topic I speak on quite a bit to kids. Vitamin D. You hear about calcium. 1/3 of the women population out there is vitamin D deficient. We don't emphasize that in the office. I try to, but by the time I go over your list of 20 medications, and we talk about grandma next door, anything else, I forget about it. But you're supposed to have around 400 international units of vitamin D a day. You synthesize your own vitamin D by sunlight. But still, it does not hurt to take a vitamin D supplement, because you may not be getting it all in your diet. So I'm a big, strong proponent of getting a vitamin that's got vitamin D, 400 international units in it a day. Exercise we talked about. Sun exposure is important for vitamin D. Now, what are some of the symptoms of osteoporosis? Now, this slide's too dark, but what it is a doctor twisting the guy until his neck breaks. You know, we can always get a diagnosis in the office if we have to. Does it hurt here or here? If we push hard enough, we get our response we want. Osteoporosis is very painless. That's what's so rough to get people on medicine and think about osteoporosis, because they don't hurt. You know, and I understand the reality, I really do. You got to buy groceries, you got to buy gas at $1.49 a gallon right now. You got to make the car payment, you got to pay $250 a month for all those prescription drugs your doctor's poisoning you on. And now I want you to take something else for osteoporosis when you don't hurt. And usually, I've already told you, you think about getting thin bones as part of the aging process. You forget about the fracture instance here. So, you know, if I don't hurt, I don't want to take something. But the reality is that it does eventually catch up with you. We know that women can lose as much as 6 inches of height by the time they're 80 years of age. 6 inches. And you've all seen people slumped over. We're not talking a teenager not getting their shoulders back. We're talking the slumping effect. That's osteoporosis. We're talking about pain and disfigurement of your joints from osteoporosis. So eventually it does get you with arthritis and osteoporosis together. Now, I just kind of touched about fracture with osteoporosis. You say, well, you get thin bones, it's part of getting older, big deal. I got to take my heart medicine, I live to be 90 years old. You know, all those things we touched about. But what's significant about osteoporosis, and this is what the public generally doesn't know, and a lot of doctors don't know, quite honestly. And we are really being bombarded in our literature now about articles on osteoporosis and therapy right now, because of various reasons. One is that in this room right now, anyone past 65, I know that 1/3 of you will have a crushed vertebrae in some time before you die. 1/3 of you. I know that the women by the time you're 65 and after, that 1/5 of you, the 1/60 of you will have a broken hip in the United States. Now I know this room's perfect. None of you are going to have broken bones. None of you are going to have any problems. But out there in the hallway with your cousins and your nieces and your grandmas and your aunts, they're at risk. And that makes it important. We know that the lifetime risk of having a fracture for a woman after 50 is roughly 40%. So let's count up our numbers here and take 40% And 40% of you are going to have some fracture because of osteoporosis, whether it be a wrist, an ankle, a finger, or unfortunately the vertebrae or a hip. We know in the United States there's roughly 1.5 million fractures a year of osteoporotic fractures in women. 700,000 of those are of the spine in your upper back. And then about 300,000 are the hip and pelvis, and the rest are peripheral. But what's important about these spine fractures is that only about 30% ever get diagnosed. You wake up, you go out and do a little gardening, do a little spading. Next day you're a little sore. Maybe for a couple of weeks, doggone that arthritis, I'm just getting old. We're finding out that only about 30% get diagnosed where these vertebrae get squished down. That's compression fracture, like taking a piece of a roll and squishing it down. And it stays there forever. And that's what happens when these people get these backs like this. They're getting fractured vertebrae, squishing, that's bent them over where they can't straighten up. They're not teenagers where you slap them around and say, get your shoulders back and look nice. They're this because they got these compressions of their vertebrae so they can't straighten up. And you've all seen them. You've seen them like this. Those are from compression fractures of the spine. Now let's really get to the heart of the significance of osteoporosis. If you're 75 years old and you break your hip, you have a 30% chance of dying within 6 months. Boy, I've got you scared now, don't I? If you break a vertebrae in here, squish a vertebrae, in 1 year's time you have a 20% chance of being dead. Because we have a lot of studies now show it goes along with other comorbid or other health factors associated with compression fracture, broken bones, that place you at risk of dying for various reasons. So most of you think, I'll break a hip, I'll pin it, and I'll be okay. 1/3 of you are at risk for dying within 6 months because of complications from your fracture. Those numbers get you a little bit. We're no longer a disease or a natural process of aging. We're now a disease, I'm telling you, that can kill you. And people don't think about that, but that's my job today on the tape series here, is to educate you about that possibility. Now, I don't want you all going out of the room today and say the world is dead, and put a bunch of Chicken Little running around, the sky is falling. But it is part of the educational process we have to make you aware of. Now, let's say you do break a hip, or you do break a wrist. Let's go with something simple. You break a wrist, no big deal. Doctor slaps a cast on it. 2 months later, I'm back using it again. It's not so. We know that when you're past 65 and you break a wrist, roughly 1/2 of you will not have normal function of that wrist again. You'll have an impairment. You won't have the grip you used to have. You won't have the motion you used to have. We know that if you break your hip, this is not a happy sight. You've all had a grandmother, an aunt, or a cousin who had to go to a nursing home because of a broken hip because they couldn't manage from a strength angle and mobility angle to manage at home. And we know that a nursing home, roughly 1 out of 5 will have to go to a nursing home after they break a hip. And we also know that another 1 out of 5 will have to be housebound. So almost half of those people past 65 who break their hip are going to have a hard time managing society without being homebound or a nursing home. Now let's raise our hand. Who wants to be in a nursing home after 65? Nobody. Okay? So I'm bringing home the point. There are significant factors associated with just breaking your bone. Now, who gets osteoporosis? The answer is back to what I said earlier. 16% of women, by the time they're 70, will have normal bones. 84% will have abnormal bones. So if you break up the room here today and even throw some men in with it, a majority of you are going to have poor bones by the time you're 70. And 93% of the people who do have those poor bones are unaware that they have a problem, because it's a thing of aging. They aren't looking for the possibility of having osteoporosis. Primarily because of hormone imbalance we listed earlier. Now, we've been beating up on the women for quite some time. It's time to beat up on the men. Men get osteoporosis also, but they get it at roughly 1/3 of the level that women do. And we know that right now that about 3 million men after 65 in the United States right now are at risk for having osteoporosis. And we know that after you're 50, about 1/3 of men will have some degree of bone thinning. But first of all, we start with a higher bone density. We start out with, so when we're thick, when you call us thicker skulled, we are thicker skulled. We have thicker bones than women. That's one of the few advantages we have over you women, is that we have thicker bones. And probably you're saying, well, that's the only advantage, and you're probably right. So we have thicker bones and we lose our bone mass slower than you do. But as we get older and we lose our testosterone vigor, then we start depleting our bone stores also, because testosterone is a big factor for men's osteoporosis, but also testosterone, whether we want to realize it or not, converts into an estrogen-like compound also and has an effect on the bone, which we just discovered this past year. So there's a little bit of women in all of us, I guess. I guess there's a feminine side to me when I have my testosterone breakdown. Now, some things that can cause osteoporosis in men. We all hear the hubbub about prostate cancer in men, and it really is a significant factor with us as we get older. But we treat men with hormone therapy to reduce testosterone. And when we do that, we treat the prostate cancer, we make more bone thinning. So there again, damned if you do, damned if you don't. We know the men as they age, but also they don't get enough exercise. We share all the same risk factors that the women do as far as on those things we talked about, the places at risk. Now, how do you diagnose osteoporosis? And this is a big area of debate with doctors right now. The gold standard for diagnosing osteoporosis is what's called a DEXA scan. A DEXA scan is a low-grade radiation X-ray that has two different individual radiation proton beams that go in your bone, and we measure how much your bone absorbs those proton beams at different angles. And we usually focus on an area of the spine and the hip and sometimes the wrist. And it's very accurate. The accuracy is like 98 to 99% of being able to diagnose osteoporosis. You're going to hear a lot as time goes on with lay literature about ultrasounds of the heel, peripheral DEXA scans, but the gold standards of the spine and the hip for determining osteoporosis. Fortunately for people over 65, Medicare came out one of the few times they give you really true benefit and said we'll pay for that every 2 years. If you're on therapy before that time, many of your insurance companies will pay for that, providing you have a category risk that we have a definition of in the office that says, yes, we'll pay for that. But primarily anyone who's on estrogen therapy or medicine therapy for osteoporosis qualifies for our insurance care to have DEXA scan paid for. There's a law enacted 2 years ago. Now, the big debate is how often you do it and how do you follow up therapy. And I lectured on this about 6 weeks ago. There's a new article came out just 2 months ago, one of our popular big medical journals, that said that it's a good way to diagnose osteoporosis, but for you to use it as a measure of how you're doing in your therapy, it's not that good. And I can be debated, because I've been debated before by the doctors who weren't afraid of burning in hell, about the fact that there's not good data to show how effective your therapy is by following your bone density on DEXA scans. Some doctors do it and that's fine, but right now there's a big debate amongst us. You know, you think you debate at home with your kids, we debate amongst ourselves all the time on scientific data on reliability of doing more tests after we do a preliminary test. So the point is, it's important if you want to know if you have osteoporosis to get a DEXA scan to diagnose it. Then it's a debate whether you should get them further on every 2 years to see how your therapy is going or not. Big debate on that right now. Now, there are some talks about urinary tests where you go pee in a bottle and we can measure chemicals that are filtered through your kidney, determine how your bone's turning over osteoporosis. Those are not readily available and they're not inexpensive. So most physicians are not recommending that urinary test to check out on how your bones are remodeling. So let's get at the heart of the whole matter here, is therapy. And you're going to hear a lot of things in your literature with the Inquirer, your Woman's Magazine, Women's Health, about how you can treat osteoporosis. And I gotta say, you can't believe everything you read. I know this happened, but there are some things you just can't believe. And what I'm going to do is go over things I know that are accepted standards that have been scientifically proven, realizing that there's a lot of things evolving now that time's going to tell if they're true or not, because they're going to have to be proven scientifically. You know, for years we used to use poultices on sores. I remember when I first came to Fairfield in 1980. My first week here, someone came in with a Mississippi River mud poultice. And I would see egg poultices, I'd see pickle poultices, and I was amazed how well they cured up things. But nothing scientifically proven. This is for later on. I don't want to forget about that. So, things you can do to prevent the progression of osteoporosis. We've already talked about exercise. Vitally important, not just from your heart, not just from motion, strength, It's important for your bones because they need impact. So walking with good walking shoes on a level surface, not on concrete all the time. Stretching, passive weight resistance, and some mild weightlifting, whether it be with a broom handle, sweeping your floor, to pushing your husband out the door, made a little rhyme there. Anything like that is beneficial. Now let's go back to diet now. I've mentioned about calcium. The big question is, how much calcium should I be taking every day, Dr. Hill? And if you're premenopausal, if you're not drinking 3 glasses of milk a day, 8-ounce glass of milk a day, low-fat milk a day, because I get that question too, is low-fat just as good as regular milk? It is for calcium. 3 glasses of milk a day, you should be on about 1,000 milligrams of calcium a day. And then they always ask me, what kind of calcium, Dr. Hill? And I said, I don't really care, because I read articles, I'm confused how much I read now. Calcium carbonate, calcium gluconate, and you've got Paul Harvey saying about what's best for his calcium. I think the main thing is get it in you, and you're going to get some degree of absorption, because calcium is not well absorbed. So if you're premenopausal, about 1,000 milligrams a day, with vitamin D, 400 international units a day. If you're after menopause, what some of you are after menopause in here today, you want to be on 1,200 to 1,500 milligrams a day of calcium. Now, if you're getting some milk products, like you're getting 1 glass of milk a day, and you're eating a serving of pudding, and you're going to get some food products we're going to mention here in a second, then you don't need quite that much. Maybe a 600 or 800 milligram tablet a day will be fine. But it's not a defined science on how much, because everyone's different, because every one of you loses rate of your calcium at a different rate. That's the beauty of man, is we have all these varieties on our metabolisms, the way we look. Some of us look better than others. And so it's not defined, but the recommendations are 1,000 to 15 milligrams of calcium, 400 international units of vitamin D. And these are standard doses. When you go to get a bottle of vitamin D, it says 400, they'll say 800. Another common question I get, well, can I take with my multivitamins? I'm a big multivitamin believer, B complex, etc. Yes, you can, because those RDAs, recommended daily allowances, they have those vitamins are substandard when it comes to supplementation with calcium, vitamin D, and E, etc. So you're not doing any harm by taking a supplement to your multivitamin every day. Now, some things in diet that are good for calcium are shrimp. So we raise our cholesterol a little bit. Who cares? Okay. I want you fat anyway, because I just told you if you're thin, you're going to get osteoporosis. Salmon, it's a good source for calcium. Molasses. How many of you like molasses? I love molasses. Don't see it that often in the store, though. Calcium fortified tofu. I don't like tofu. I probably would. She probably does. I heard go. But if you get 3 ounces of tofu a day, you get roughly 60% of your calcium requirements. Good food filler, good protein source. If you like almonds, you like your nuts, almonds are a good source of calcium. There again, forget your cholesterol. Better switch to tofu so you don't raise your cholesterol with that. Dark green vegetables, green leafy vegetables are very important for calcium metabolism. But I want to tell you, it's not enough if you have osteoporosis or you're at high risk for osteoporosis to prevent it. In other words, you can take your 3 ounces of tofu, you can eat your 3 glasses of milk a day, drink your 3 glasses of milk a day, and do all this with exercise. If you have osteoporosis, we're going to talk about in treatment here in a second, it's not enough to prevent the progression of it. You slow the progression, but you don't prevent the progression with just diet and exercise alone. We know that statistically now, because they've done several side-by-side studies now of calcium alone, calcium and vitamin D alone, calcium with vitamin D and exercise alone, and then comparative side-by-side studies versus taking pharmacological agents with that, and they don't pair up near as well. And we can debate about that too, but I'm talking about medical scientific literature here right now. Another product that I doubt many of you utilize is soy products. Get your soy burgers, good source of calcium. If you go to your organic food stores, if they can find isoflavone extract, those are natural plant estrogens, isoflavones. Now, some of your places can get the powder where you would take about 30 to 45 milligrams a day that you can put in milk or juice, and that gives you a good source of calcium. And with that, you meet roughly 70 to 80% of your calcium requirements if you want to go that route on soy products. We mentioned weight a little bit. I think that if you want to use something for your source of fats for your cooking, we do know that olive oil and fish product oils do help on calcium metabolism. So outside of heart health, we know they're healthy for the bone also. We've mentioned caffeine and alcohol. Caffeine, maybe I have mentioned before. How much caffeine is okay for osteoporosis? No one thinks about caffeine being a risk factor, but if you drink over 8 cups of caffeine a day, you're at high risk for getting osteoporosis, particularly in men more than women. So limit your caffeine to under 8 cups a day. My personal feeling, you shouldn't have any more than 1 or 2 cups a day anyway, and I don't like caffeine anyway. Because caffeine breaks down into over 1,000 ingredients on a biological survey analysis. We haven't even defined it. And we know it affects the bladder, affects your nerves, it has a lot of things. So I don't like caffeine, period. Vitamins. I mentioned multivitamins, calcium, and I'm always careful about recommending this because if you have some impaired bleeding disorders, it can put you at risk. But vitamin K, if you just take 1 milligram a day, and you can buy vitamin K, 1 milligram a day, what it does, it works in the kidney so that you don't release as much calcium from your urine and cause you to keep your calcium stores in circulation being readily available for your bone metabolism. It diminishes calcium elimination by about 30% by taking 1 milligram of vitamin K a day. Magnesium. And once we hear about selenium, magnesium, etc., 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 chromium, I hear all those things. But magnesium, if you take about 350 milligrams a day, helps you prevent loss of calcium. We also know it also helps prevent potassium loss too. So magnesium, you can buy a variety of magnesium products over the counter too. Some good natural sources for magnesium though are basically spinach, potatoes, unless you're on a high protein diet you can have potatoes, beets, nuts, and fish. So there again, eating healthy, which most of us are getting out of the habit of, can meet most of your requirements for magnesium, phosphorus, and calcium if you just take a little time to do it. But we're in a busy society. You know, you got to go to Hardee's, etc. I shouldn't do any names since it's on the F-Pack here. Go get a burger, French fries. It's easier to go and fix a salad with greens and things on it at home. Now, quit smoking. You hear us talk about that all the time. And smoking places you at risk for osteoporosis also, besides all the things you're well aware of. Heart, stroke. And you know, if 45% of women are going to die from stroke and heart attack, they definitely want to be getting away from smoking. And unfortunately, the incidence of women smoking is rising every year in the United States. One thing we forget to talk about for prevention of osteoporosis, and particularly prevention of fracture, is to prevent falling. And there's studies going all the time how to prevent falling in individuals. Things like throw rugs in your house, rough edges of your carpeting, transition points between linoleum and tile to carpeting, a wet floor surface coming out of the shower stall itself but not having pads down to prevent slipping and falling. So we need to work harder at talking about prevention of falls because that's important too because of this compression fracture. That's how most of these happen. Lifting something, lifting a box of clothes, a laundry, going up and down stairs and slipping, and then strengthening. We talked about light weightlifting. Now, I've gone and spent about just 5 minutes talking about 4 different basic drug classifications to give you the highlights. And this is usually where I'm talking to medical students and the physicians around different areas. There's 4 basic groups of medicine, prescriptions-wise, for osteoporosis in the United States right now. Estrogen therapy, which is like your Premarin, that you're all aware of. They have estrogen formed by soy-based products. They have estrogen formed from horse urine. When you take Premarin, it's made from horse urine extract. They take the estrogen out of that. Didn't know that, did you? But there's a bunch of unhappy horses with diapers out there giving you estrogen extract. But they have a lot of synthetic estrogens, and you hear a lot about natural estrogens from your isoflavones. But we do know they do help prevent osteoporosis, and we don't know as much about the natural products yet because we're just not really getting a good look at those. But they, besides preventing osteoporosis, they have much benefit for your lipids, your cholesterol. They have a big advantage for colon cancer prevention, for retinal deterioration in your eyes, sensorium, thinking ability, not prevention of Alzheimer's. A study just came out this January in one of the JAMAs showing it didn't reduce Alzheimer's like we thought it might. There are many multi-system advantages to estrogen. Your disadvantages you worry about, and we have to think about. Breast cancer risk, uterine cancer risk and bleeding, breast soreness. But I want to reassure you, if you take estrogen therapy, the scientific data evolved the past 50 years show that unless you're at tremendously high risk of breast cancer, for example, a mother, sister, and aunt with breast cancer, that a 5-year use of estrogen is pretty safe from those things I just mentioned. After that, I've got articles I speak about that talk about how your risk of breast cancer starts going up despite the medical suppliers of that product line trying to argue the point contrary. So don't be afraid, and you need to talk to your doctor specifically about the pros and cons of estrogen, to use estrogen for osteoporosis. And there'll be other medicine he'll talk to you about to prevent you from some of those side effects if you have to go that route. Very effective tool, very good for reducing fracture and bone thinning. The one product I usually talk about, because the company sponsored me talking to doctors, is called Evista, Raloxifene. It's called a designer estrogen, selective estrogen receptor modulator. What it does, though, it doesn't affect the breast and doesn't affect the uterus. And right now it's showing about a 74% reduction of breast cancer with using this drug. The disadvantage, it doesn't help hot flashes that you go through menopause. But it prevents bone thinning, prevents fracture. It's indicated for fracture therapy, but it doesn't help hot flashes. And estrogens and SERMs both have a contraindication if you've had blood clots and if you have bad leg cramps. So those are things your doctor has to talk about. But there again, it affects cholesterol, helps prevent heart disease, we believe, and has a lot of other added benefits. Which gets back to why I brought that topic up earlier about your perception of dying of breast cancer and the reality of dying from heart and cardiovascular disease. Bisphosphonates, Fosamax, a new product coming out this year under the name of Resendronate with another trade name, work in the bone directly to prevent bone thinning. All they do is specifically work at bone thinning. They have no advantage to breast, uterus, anything else, cardiovascular disease, but they're specifically for bone. And statistically, they had the best track record for helping restore your bone. But they have side effects on gastrointestinal, as far as nausea. Although the company that supply the drug say that it doesn't have a placebo ratio. When I've tried it, I have a fair number of people that don't like it because it makes them nauseated. So we're working through that now. And then one other product line called Calcitonin. It's a spray. You put up your nostril one time a day, gets absorbed in the mucosa of the nose, and helps prevent the bone loss of calcium also. And there's studies going on in Europe that are showing it helps reduce hip fracture rates and thoracic spine rates. And we work, a lot of studies I look at are done in Europe and the United States because it's cheaper to do studies in Europe. To do a study to bring a new product line to you in America right now runs about $1 billion. From the time they develop the concept, the time they go through their research, their marketing, and hit the shelves, it's $1 billion expense for them to bring a new product line out. And they can do it for almost half the price in Europe. So a lot of studies I look at are done in Europe and the United States. But those are the 4 basic groups of prescription medications that you take in supplementation to your diet and activity. Now, before I open myself up to questions and answers, remind you, you burn in hell if you disagree with me very much. And I want to remind you, tax season's coming up here pretty quick. Make sure you got your taxes done. We don't want any more stress in your life. This says that I beat the taxman. This guy says, no, he hasn't. He's in Bermuda there following around. So I'm open to questions. I'm going to turn off the slide projector here. And I'm open to any questions. If I don't, I guess I've done my job. Have any questions? I've done my job. But I'm more than welcome. If I don't know the answer, I'll tell you and I'll get the information. But does anybody have any questions?
How young should girls start taking calcium stuff? Where they know that there's a disease in the family?
I should pay you for that question because that's something I forgot to talk about that's very important. Our teenagers eat lousy. And I got 2 beautiful teenage girls and they eat lousy. They're worried about their fat. You know, don't want to eat this, don't want to eat that, don't want to eat meat because I don't want to I'll get fat. And our teenagers are doing a lousy job on getting adequate calcium and protein. If you got a daughter or a granddaughter or niece that has her hair falling out, she's probably not getting enough protein. Because they're so worried about being a vegetarian diet and they're not getting enough soy products, the tofu and things to maintain their protein. But calcium, they don't want to drink milk. And when we all grew up in our generation, you had to drink milk. Now it's like it's in vogue not to drink milk. So very few teenagers drink 3 8-ounce glasses of milk a day. Or eat some pudding with milk, etc., and those things we mentioned. So a teenage girl who has poor milk consumption, or a boy for that matter, should have calcium supplementation. Now getting them to take it's another thing. Take away the keys to the car, take away the computer, take away the phone. You might get them convinced otherwise. But if I had a teenager who didn't have any milk products, they should be on at least 800 to 1,000 milligrams a day. And exercise. Another thing I see in the office, the rate of our youth not being aerobically conditioned. Because they're driving anywhere, they're riding a moped everywhere, and they're not walking and not doing physical exercise like all you good people here did, working out and raise a living and, you know, walk 20 miles to school in snowdrifts 6 feet deep. So it's a good question. And we're not doing a very good job on learning. Because remember, by the time you're 30, you've reached your maximum bone density. It's over. And by 40, you're over the hill. So you got to do your job with these kids to get the calcium stores up there because it's important. Any more questions? I'm sorry. On estrogen therapy, yes, and that's one of the things that my company has me argue about. On estrogen therapy, it raises your triglycerides anywhere from 30 to 80% on estrogen compounds. On prescription, the soy isoflavone estrogen compounds say they don't. The SERMs, the one I mentioned about Evista, does not. It reduces and leaves at level triglycerides. So it depends on the product line you're on, so it can raise triglycerides. It depends on where your baseline is. If your triglyceride starts at 150 and under, it's not a tremendous risk. If your triglycerides are 250, 300, I'd be a little cautious. But you got to weigh the pros and cons.
I just got my blood test back and I think it's
Yeah.
what, 100
Well, you should probably address that. And that brings on a topic. The American Heart Association came out with a specific set of guidelines for women this past year. And they're more stringent than they are for men. So we can eat our steaks more often. With women, they say your triglyceride ideally. Now we're looking at an ideal world here. Because I realize ideal world doesn't always exist in reality. But if you want a goal, you want your triglycerides under 150. You want your LDL, the bad cholesterol, under 120. And if you have heart disease, under 100. You want your total cholesterol around 200, but you wouldn't have to necessarily start therapy unless you're over 240. Good cholesterol, HDL, should be over 45 to 50. And you're good there. And you got to look at your LDL. But triglycerides being elevated do carry some risk with your pancreas for diabetes progression as you get older. But it doesn't have as much contributing role to triglyceride. I'll just mention briefly what happens with women with estrogen is it raises triglyceride. It converts it into another subset of type of fats in your liver that places you more heart risk for hardening the arteries. That's what the concern is. So it depends on what your baseline is and follow. And remember, that's a general rule. Doesn't mean it's going to happen to you. So if you get estrogen therapy, check your triglycerides and see where they're going. You probably should consider thinking about treating your triglycerides anyway, at 500 levels.
Now, on your total cholesterol, if you rate your good cholesterol, HDL, it's supposed to be like 90 or so, then it'll raise your total cholesterol, but I think that's good when your LDL is low.
Yes.
Because it still will be a higher total cholesterol, but it's still good if you've got good.
That's right. You have to look at your ratios.
Yeah.
Initially, we just started hearing about cholesterol. Now the big word is LDL. First was HDL, good cholesterol. You had to have it above 40. Then we realized LDL, low density lipoproteins, bad cholesterol, had to be below this level. But it comes down to the ratio of good versus bad, good versus evil. So if you had a cholesterol 240, but you got an LDL of 120 and HDL of 50, I'm not too worried about that. Unless you're a smoker and your mom died in her 50s of heart disease. Then I get a little more aggressive. So there again, it's the art of medicine. When I give talks in past, I always talk about the art of medicine. Everyone's individualized. In your case, you have to individualize your therapy. What's your risk for heart disease? Is it a concern for you? Is there a strong family history of diabetes? New concern, is there a family history of heart disease or stroke at a young age that you may want to drive that cholesterol down and raise up your HDL and lower your LDL with medication, or just by bringing down your cholesterol, increase your ratios? Yes?
So what's the difference with a male
If you're on, you have a good case, and they can approve that on a case-by-case basis, but I want to tell you, if you work with government bureaucracy, you realize that would be 3 to 6 months to iron out. If you're on prednisone therapy, say for example rheumatoid arthritis or lung disease, and if you're on a maintenance dose of over 7.5 milligrams a day for 3 months, you qualify. If you're on therapy specifically because of repetitive fractures, on defined osteoporosis, then they cover it also. So it probably will carry with you, but the emphasis has been with the new law on women osteoporosis bone DEXA scanning. But your doctor can individually supply the information, and they probably will okay it on that basis. Remember, we're being left out in the woods, guys. Face it. Focus on women's health. Forget about us. Yes. Yes, you can. Well, I don't think you want to go over 2,000 milligrams a day. I think I would keep it by the RDA, what I told you about 1,500 milligrams. And the reason being, if you take too much and you don't eliminate it, then you can run out of 1% I told you about circulating calcium to be elevated and place you at risk for things, although they're arguing about that right now, about kidney stones, and that's important. And that's a question I didn't cover. If you have a history of kidney stones, for years we said you can't take calcium supplement. The research shows it really doesn't affect it. All right. So if you have kidney stones, your urologist tells you can't take calcium. If you're a female, the studies show you can. I guess it's one of those things we've held on to with our river mud from Mississippi poultice. So you can take calcium. That's been shown. No, I think the supplement. Because you have very low rate of absorption. When you're taking 1,500 milligrams of calcium, you're only absorbing maybe about 1/5 of that at most. Any other questions? Anyone? Okay.
Are there any long-term effects?
In what sense? Because that's why I lecture on. Yeah. Well, right now, I see the data from the past 8 years from European and things. That's what I lecture on that topic. And we don't have any bad long-term side effects. Unless the contraindication I talked about. Blood clots, which the incidence is low. The actual risk of getting blood clot on Vista is 28 per 100,000 people. Similar to birth control pills. So it tells you taking a birth control pill. But the benefits of heart, breast cancer reduction, not affecting uterus, not causing breast pain, all advantageous. Reduction of fracture risk, prevention of fracture, treating fracture, cardiovascular risk. There's 2 studies we've got right now going on. One's the ROOS study, one's the STAR study. The STAR study comparing Evista to tamoxifen, which is the one that just made all the newspaper about preventing breast cancer. You have a 5-year family risk, you take it for 5 years, and we also give it for women who have breast cancer for 5 years. And there's a study going on right now, and I can't speak about the numbers except it's very favorable on how it's responding to breast tissue for preventing breast cancer. As far as the ROOS study, it's a 5-year study of roughly, I want to say 10,000 women nationally. And we're evaluating the benefits of preventing heart disease and stroke with Evista. And I can tell you, I can't speak about what the numbers are showing, but I sure wouldn't be afraid about taking it on those bases. So blood clot risk is the thing you got to remember. And if your wife gets bad leg cramps, they don't go away. You got to stop it for that. Aspirin does not prevent blood clots either on Evista. People think taking aspirin doesn't do that for that. Anything else? Anybody want to disagree with me? All right. Thank you very much for being here today. It's been fun. Always willing to talk to a group of people. Thank you.